So I think I welcome you all. We can't have a more fair distribution of radiation oncologists, medical oncologists, and surgical oncologists than we have in this panel. And also there is a fairly, I think, biased gender distribution, but that's okay. So let us start with the first case.
So we'll begin with our first case. We have a 30-year-old unmarried lady with no comorbidities. She presented with complaint of intermenstrual pervaginal bleeding and spotting. On examination under anesthesia and vaginal mapping of the disease, we found that cervix is bulky, posterior lip is enlarged, vagina is normal. Iodine uptake was seen in all the fornices and vagina. On PV examination, there was a 2 × 2 centimeter tumor felt at the posterior lip of the cervix. The rest of the findings were normal. And this is the biopsy. So I would request Dr. Kedar to highlight the importance of large cell versus small cell neuroendocrine carcinoma, and is there a difference between the two in terms of prognosis?
First of all, I think Dr. Prabhat made a very valid point that we use carcinoid terminology only in the context of ovary, and that is usually associated with mature teratomas of the ovary. In cervix, endometrium, and other vulval organs, we do use now neuroendocrine tumor or neuroendocrine carcinomas. In neuroendocrine tumors, they are actually exceedingly rare in cervix. So when what we would put equivalent as carcinoid in cervix, most of the neuroendocrine tumors in the cervix are actually neuroendocrine carcinomas. They are undoubtedly high-grade tumors, high MIG-1 index, high mitotic activity. And part of those will be small cell type, as Dr. Prabhat mentioned the point. And morphologically, they are small cell carcinomas based on the cytology, whereas some of them are large cell neuroendocrine carcinomas, but uniformly, they will express neuroendocrine markers, cytokeratin usually dot-like expression. So this particular tumor is chromogranin positivity, P16 block length positivity in this context, because most of them, 70–75% are associated with HPV 16 and 18. So that explains P16 positivity. CEA, P40, CEA is an adenocarcinoma marker, P40 is a squamous cell marker. And so hence large cell neuroendocrine carcinoma is actually the diagnosis. And undoubtedly, these will be actually very high in the MIG-1 index, so 60, 70, 80%.
So I just want to ask one question, Kedar. Is this the IHC panel that you would want when you are suspecting a neuroendocrine tumor, or you would want to do more markers? Because chromogranin is very specific but not very sensitive, right? And then there are newer markers which are coming up. So do you think we can incorporate that in our practice?
Synaptophysin is a very good marker in our practice, but a newer marker, INSM1, is actually a very useful marker, which is more specific, which gives us this diagnosis. We do use CD56, but it's not very specific in that context. So INSM1, good marker.
So that should be included as a part if there is a doubt.
Yes.
Okay. And
exclude fairly squamous and adenocarcinoma, and then reach this type.
Okay. So on the metastatic workup, we did the PET scan. We did not find any abnormal focal metabolic activity in the region of the cervix, or there were no distant metastasis seen. I would like to ask Dr. Sneha, on biopsy, there is a tumor identified. Why there was no uptake on the PET scan?
What PET was this? Was it a FDG PET or a gallium-68?
It was an
other
FDG PET.
So if you go back and see the size was 2 centimeters. And we all know that the cervix region is masked by a presence of a bladder. With a very small lesion and low uptake, if the bladder has activity present in it, there could be a false negative impression of no uptake being seen in the cervix. So generally, when we evaluate patients with small lesions and per se in the pelvic region, we ask the patient to avoid urine just before the scanning, such that the bladder is empty. And then you'll be able to pick up even very small size, which is not often done, and that's why you might miss out. Very thin mucosal disease may also not pick up FDG uptake because of the small cells which are present in those tumors. So uptake is based on the presence of number of cells. If the cells are small, any mucosal disease can be missed on a PET-CT.
Thank you.
Can I also, just since there was a discussion earlier and I don't know that, So if you have to look at neuroendocrine tumors, you can do a gallium-68 PET-CT. That is a somatostatin receptor analog. That's why I asked first which one.
Even in high grade neuroendocrine carcinoma?
Not in high grade. Because you already have here, we wouldn't do it. But if you had a low grade, then yes, you would have to do a gallium-68 somatostatin receptor PET-CT.
MRI pelvis revealed a plaque-like thickening involving the cervical lip thickness of 5 mm. Dr. Akshay, do you think you're confident in labeling it as a disease if you are not aware of the biopsy report?
No, so we can, it's very uncommon for us to be able to identify prospectively that is a neuroendocrine carcinoma. We won't be able to do that. We will only be able to identify that there is some lesion there. And, usually we will assume that's carcinoma. But NEC, we don't have any specific imaging features.
So I think that should be the sequence of evaluation, right? In most of the patients with neuroendocrine tumor, that you do a PET-CT first, rule out distant metastasis, and then if you're planning for surgery, then go for MRI pelvis. Probably you can avoid one investigation in case if there are already distant metastasis. So I think this is the question, to Dr. Anbu, what would you think? Would you want to go ahead with surgery, or you would still consider something else?
Cases that is actually presented in an early stage. We hardly see even squamous or adenocarcinomas at a 2 centimeter stage. So I think she's an ideal case for surgery.
Yeah. So what surgery would you offer?
May type C nerve sparing with no dissection.
And would you think of doing ovarian conservation or ovarian transposition in this patient?
Yes, considering that she's young and I don't know her family history, but it would be a good opportunity to conserve her ovaries because many of these cases can be treated with just surgery and chemotherapy, and we may be able to reserve radiation that for a later point. So it does make sense to conserve her ovaries and transpose it as well.
So the question is, as far as we were, we're learning, I think most of the times you would not advise ovarian transposition in an adenocarcinoma, right?
Yes.
Where the risk of ovarian metastasis was about 3 to 5%. So how safe it is, to consider ovarian transposition in a tumor which has a propensity, to have a larger propensity of metastasis than a conventional adenocarcinoma of the
We really
cervix?
don't know the numbers. We really don't know the exact incidence of ovarian metastasis. So if it's grossly looking normal, if MRI is normal, considering her age, I think it's a calculated decision that we have to take along with the patient.
Okay. So I think, we all agree that yes, that is an option that can be considered in the younger patient. So that's what this patient underwent. I think she underwent radical hysterectomy and nerve sparing, bilateral pelvic node dissection, bilateral salpingectomy, and ovarian transposition. So, this was what was done, and this is the final histopath report.
So this is the histopathology report. The tumor size is 2.4 centimeter. The stromal invasion was seen in the inner 1/3 of the stroma. Parametrium was free. Rest anywhere else there was no disease, and 0 out of 10 lymph nodes. So how would you manage this patient? Dr. Jaya, what would be your choice of treatment in this patient?
The tumor would definitely want to give her at least 4 cycles of cisplatin etoposide, and also because it's a high grade, we can think about the sequence, but ask my radiation colleagues whether for chemo radiation for these patients. This was a 2 centimeter, sorry, that's para.
2 centimeters.
2 centimeter.
And node negative.
Node negative. Para-free.
And all the lymph nodes were negative.
All negative.
So definitely for this patient, I would at least give 4 cycles of cisplatinum and etoposide because of the high risk of systemic relapse. Well, there was just when I was looking at the data whether to give more chemo, but by general, we would usually give her 4 cycles of chemotherapy.
Dr. Vinita, would you add radiation in this patient or not?
In high-grade neuroendocrine carcinomas, I think the outcome is driven by the biology of the disease rather than the stage. So I think I agree with Dr. Jaya. Observation is certainly out, and this patient merits adjuvant chemotherapy first. And I see little reasons for adding radiation therapy because she's node negative, margin negative, and it's a small tumor.
Thank you. So this has already been covered, that this is a retrospective analysis where it was seen that if the number of chemotherapy cycle is 5 or more, the outcome is better compared to less than 5 5 number of cycles of chemotherapy, and this is an analysis in early stage neuroendocrine carcinoma stage 1 and 2. Similarly, there is no benefit of adding chemotherapy in patient who had early stage neuroendocrine carcinoma post-surgery. In the interest of time, I would skip this and we'll go ahead to the second case. To give chemo.
My only question is, I think if you go by, if I may add, if you go by the guidelines, I think irrespective of the stage, every guideline suggests that the patient should receive radiation, right? And yes, for early stage, no, for small cell neuroendocrine.
So in small cell neuroendocrine carcinomas, only Japanese data recommends that adjuvant radiation therapy has to be given irrespective of histopathology report.
Correct.
The other data does not actually routinely recommend it. However, the rate of local recurrences are high, reported to be high even after surgery. Regarding your question as to why operate, the only advantage of surgery, as I see in this patient, is that surgery can be over very soon. While radiation therapy would take 5 to 6 weeks, although concurrent
That's
chemotherapy can be added, but then it is in the lower dose as compared to the, the doses of adjuvant chemotherapy. And the risk of systemic relapse is pretty high here. We would be happy to treat this patient with concurrent CT-RT also, but then, surgery takes much lesser time, is my opinion.
So in that larger series with the National Cancer Database, the patients that had the longest survival fit into this category, which is the smaller tumors, and they received only chemotherapy. So general recommendations are, if it's an early stage, you can combine with just chemo and keep radiation for the more advanced, locally advanced tumors or metastatic.
So I have not shown those slides where there's a in fact, there are two retrospective analyses which looked at whether surgery should be done first or CT-RT. It was seen that patient who underwent surgery, they had a better outcome compared to those patients who were treated with radiation in early stage neuroendocrine carcinoma. So moving ahead to the second case, we have a 20, we'll take this later. We have 25-year-old unmarried lady with no comorbidities, presented with irregular menstrual cycle, loss of appetite and early satiety. CT scan revealed a well-defined thin walled cystic lesion, 22 centimeter with septation, mild ascites and few omental deposits. Her tumor markers were within the normal range. How would you manage this case? Dr. Seema, please.
She's a young lady with ovarian mass, will proceed with surgery and surgical staging with in keeping in mind option of conservative surgery, fertility preservation, and it all depends on the intraoperative frozen section. Most probably with a large tumor, this is going to be a mucinous tumor. So I'll rely on the frozen. If it's borderline, I'll just finish it at peritoneal staging and.
So I think let us start with the surgery. Would you go for open surgery or would you consider
Definitely. The
laparoscopy?
tumor size, can I see slide once more?
It's 22 centimeters.
Definitely open surgery.
Definitely. So that is
I
one
think
thing we all agree. I think, is there anybody who would want to consider laparoscopy in this patient?
I don't think in
So
this
I think
crowd anybody will
open
do that.
surgery is the way forward. Okay,
Okay.
then. So then you would want to remove the mass and send it for frozen section. So I think here comes the role of pathologist, which is probably the most difficult one. Kedar, I want to ask you three questions, so how accurate is frozen section in terms of diagnosing mucinous ovarian carcinomas? Okay, two, with what certainty can you tell us, whether it's expansile or infiltrative, if at all you can? And three, how accurate you can be in terms of differentiating whether it's coming from GI or coming from primary ovary? So these are three questions that I, as a surgeon, I would want to know when I am operating a case.
Okay. When we have done our audit of frozen section comparison with frozen section and paraffin report, in our hands, our accuracy is about 86 to 90, between 86 to 92%. In our hands, it is about 89%. So it's possible that in 10% we are wrong. But our general practice is that in the mucinous tumor, we would rather say a borderline mucinous ovarian tumor if we don't see any specific or definitive area of stromal invasion. So that is the general dictum. As regards to what was the second question?
Expansile versus infiltrative.
Expansile. So we will maximally take about 3 sections in a 22 centimeter tumor mass. I would say we will be fairly reasonably certain to say expansile, but that is provided if we diagnose it as a carcinoma. If most of the times when we see a younger lady and a mucinous tumor, generally what we see is that there's no definitive stromal invasion. We will always end up calling a borderline mucinous tumor. That is the more likely, that is diagnosis which is coming from our end. As regards to your third question, whether how confident we are, when we, at frozen section, we cannot distinguish between primary mucinous tumor of the ovary or it is coming from GM5. In fact, it can be a struggle even at the paraffin section. And there what we do is we usually use this bilateral, how the status of appendix. But in addition to that, certain immunomarkers can be helpful. One is a PAX8, which is a Mullerian marker. And see, by definition, mucinous tumors of the ovary shows intestinal differentiation. So only positivity of the intestinal marker doesn't make it definitely intestinal origin. But if given mucinous ovarian tumor, if it's PAX8 positive or say ER positive, some people use CA125 positive. These are the markers which can support your diagnosis, lend support to the diagnosis of primary ovarian tumor, mucinous tumor. Then we will use those and then try to distinguish between at the final stage whether it's ovarian primary mucinous ovarian or coming from GI.
Yeah. So what I understand from your explanation is that there are no specific markers for mucinous ovarian cancer per se, and most of the times a primary mucinous ovarian carcinoma histopathologically is more of diagnosis by exclusion rather than having so if they test negative for other GI markers, you are more likely to favor a primary mucinous ovarian.
If the Mullerian markers are positive, such as CA125, PAX8 is the most important, and ER, then I'm more confident to say it is this mucinous tumor is actually indeed primary ovarian in nature than a secondary tumor.
Okay. So I think
Signet ring will not give us any idea because such appearance of signet ring cells can be seen in primary.
May I ask a question?
yes.
Kedar, in what percentage is your frozen diagnosis of mucinous borderline upgraded to invasion on final histopathology?
I don't have a number, but it's mostly actually the diagnosis of borderline mucinous tumor remains as borderline mucinous tumor because you can look at younger ladies with 22%, 22 centimeter size with multiloculated cystic with no solid areas. 80-90% is going to be borderline mucinous tumor. Yeah.
Kedar,
So I think
if I may ask you, I don't know if it's working. Well, I would like to know as a surgeon, during surgery,
Right.
whether it's primary or metastatic, all those immunohistochemistry markers are fine. I want to know as a surgeon during surgery, is it possible? Not possible.
Sir, secondary mucinous carcinoma coming to ovary. Actually, if I can say actually it is a carcinoma, then sometimes I can say it is likely to be secondary from some other organ. But that is provided I reach a diagnosis of carcinoma. Most of the times we struggle with mucinous tumors in younger ladies, and those are borderline tumors. In such cases, the answer from me is actually no.
Yeah.
I can't.
So I think this is the final histopathology report. It was a mucinous adenocarcinoma with expansile pattern and the momentum was negative. Rest of the things.
Capsule was involved,
yeah.
so this patient has stage 1C disease. So how would you treat her? Dr. Jaya Ghosh?
So, yeah, so I just want one point I just want surgically to address before we move on to that. So how many of you would, if somebody tells you a diagnosis of mucinous adenocarcinoma on frozen section, would go ahead and do a lymphadenectomy, or how many of you would wait and wait for the final HPR and then consider lymphadenectomy?
Our practice, we don't do lymphadenectomy and Madam has suggested doing, but in our practice, we have stopped doing lymphadenectomy for mucinous cancer. So basically the frozen doesn't make much of a difference. It's borderline or malignant. I'll be doing peritoneal staging, a tomentectomy, peritoneal biopsies and plus or minus appendicectomy.
And suppose the final HPR comes as infiltrative type, which has shown to have higher risk of nodal metastasis, would you go back in?
That is what we are discussing. We must,
So
there is an
because
option of going back and.
correct, because here the issue is these are not the tumors which are chemosensitive, right? So you do not want the disease to be left behind in case if it is infiltrative. So I think, if it's an infiltrative diagnosis, which is not very common, we may still have to go back in and do a lymph node dissection if you have not done a lymph node dissection. Yeah. Yes, that should be fine. The route is, as long as we are able to do a complete job, the route is not important. Yeah, the other thing is, routine appendectomy. I think that question has been addressed. And I think the current consensus is, if the appendix is found normal on examination, you would not want to do an appendectomy. Yeah, sorry.
So I wanted to ask you about the lymphadenectomy. If the lymph nodes are not palpable, if they are not abnormal during surgery, then where is the evidence that anyways performing lymphadenectomy will improve outcome? I mean, regardless of whether they are infiltrative,
No.
non-infiltrative, serous, mucinous, whatever. So you palpate the retroperitoneum. If there are no proper, if the lymph nodes are not abnormal, then how would
Sir, the
lymphadenectomy help?
only logic that I can apply here, sir, is that, if it's a chemosensitive tumor and if there are, metastasis in the lymph node, the chemo would take care of it. In mucinous adenocarcinomas where you're not sure whether the chemo is likely to work, and if there is a high risk of nodal metastasis, it would be a decent idea to take it out. I mean, I'm not sure. There is no evidence for whether in early or advanced ovarian cancer that lymphadenectomy improves survival either ways. But I think it will help you in terms of stage properly, and probably in not so chemosensitive tumors, I would be more inclined to do that.
I think same thing
So
what Dr. Gupta just asked, is that you just mentioned that once the borderline tumor, is given in frozen and you have not removed the lymph nodes, and afterwards it's upstage to, malignant, then is there really a reason to go back and do lymphadenectomy unless you are trying to change the treatment? That means if your treatment tells you, if the staging comes that you have to give chemo, then do you still go ahead and do
Correct.
lymphadenectomy?
Now,
You
my
don't have
answer to this question is, I would look at the probability. If the infiltrative mucinous carcinomas has a probability of lymph node metastasis of 20%, okay, and for the sake of staging, at least we will need to do that, right? Because in either case, so even in serous carcinomas or germ cell tumors, there is no evidence that lymphadenectomy improves survival,
Exactly.
right? We still go ahead and do it, right? For our information in terms of identifying accurate staging and prognostication of patients.
So if you have to do it for a staging purposes which avoids chemo, then it is justified.
But the thing
Otherwise,
is, so
if you have
suppose,
to give a chemo immediately after the surgery, then why should you be going again and doing
because I'm concerned whether chemo will work or not in case if the nodes are positive.
Can I
That's the logic.
Finalists also to respond to that.
I just make a comment that, of course, those with infiltrative pattern have a higher propensity of metastasis. But I don't know, when the tumors come back, I mean, of course, we've also been doing this infiltrative lately. So it is not that they always come back in lymph node, they might come back with various distant metastases. So I'm also not sure how, of course, there's no evidence for that, but if they are not going to come back in the lymph node, but they'll come back with like something like lung metastasis, skin metastasis, of course, these are rare tumors. So then, and you may be doing a lymphadenectomy for somebody who has like a borderline and a expansile pattern where the outcomes are anyways good, whether that could have an effect.
So I
Can
mean,
I just add something?
We are not doing lymphadenectomy.
Can I just add something?
Can we have
Sir
from
wants to
Dr.
add.
Hemant? He's been standing for a long time.
My only point is, even if you diagnose an infiltrating mucinous carcinoma during surgery, and if the lymph nodes are not palpable, would you be still doing a lymph node dissection in these patients? Well, no, listen to me. The risk of lymph node metastasis in mucinous carcinoma, even infiltrating, is quite low. Majority of times, these lymph nodes are palpable. So you're excluding that. So the chance that you'll really miss these lymph nodes is not more than 4%. And that's the literature. So if you have already closed the patient, I don't see any need to go in again and do that. Well, during surgery, whether to do or not is the individual philosophy. But once you've done that, I don't think one needs to go in.
Okay.
I think it's a very,
So I think that
it's,
I'm only make it
we are
seconds.
we are
See,
running.
As a surgeon, I just want to say something. Doing lymphadenectomy is not very difficult. So let us not get onto this, that why are we doing lymphadenectomy? It is easily done. And of course, I do agree that lymph node metastasis and mucinous carcinoma is very low. But then, like I presented before, if it is infiltrative type, definitely DFS and OS gets affected. Also, this concept about palpating lymph nodes and trying to remove palpable lymph nodes is so far for me is a little difficult to understand. Many of these patients are very obese, and when you're palpating, you don't know whether you're palpating fat or whether you're palpating lymph nodes actually. So it's always better if at all your intention is there to do retroperitoneal lymph node dissection, then just please do it.
It's a controversial issue. Can I just make one comment?
I would
I think
request
we
to
have to
end
move
the
on.
discussion on lymphadenectomy now, and we'll move ahead to
I
the
think-
systemic therapy.
Just one comment, just one comment. It is a controversial issue. We all agree, and I think all the panelists, as well as I think all the experts, have already commented that the nodal positivity is less than 5%. I think there is no need of going ahead with that of the node dissection in the mucinous carcinoma. What require? We do not have any evidence to suggest going for the lymphadenectomy, giving good survival, or you follow them up and then act at that time. So I think this requires to be actually addressed later.
So I-
For final
Go
word
ahead,
from
please.
chairperson, we end this discussion here. Now, for regarding systemic therapy, Dr. Lakshmi Haridas, what would be your choice of therapy in this patient? She is stage 1C expansile pattern mucinous carcinoma.
I believe she has undergone the fertility preservation.
Yeah.
Yeah, so I would go ahead with chemotherapy. Both these are options like paclitaxel and GI-based chemotherapy. Even though we have retrospective, a small series which was presented 2 years
What
back.
would be your choice? You just,
Paclitaxel.
okay. Dr.
Six
Jaya
cycles.
Ghosh, what would be your choice? One line, please.
Because it is 1C, we use paclitaxel and carboplatin-based chemotherapy
Okay.
cycles, but
So we all know this. We'll skip. So we will quickly take only the management related question in case number 3. This is a 43-year-old lady with diabetes in November 2019. She presented with abdominal distension and abdominal pain. This is the CT images. Clinically, she is in stage 3C. And this is the biopsy report, which is low-grade serous carcinoma. And this is the IHC, which confirms the diagnosis of low-grade serous carcinoma. How would you treat her? Dr. Anbu Subian, would you give neoadjuvant chemotherapy or would you operate?
If the CT shows that we can safely operate and achieve zero residual going for surgery, if not neoadjuvant.
So I think we don't have the CT scan, these are the CT films. The patient has gross ascites and the biopsy is low-grade serous carcinoma. Yeah. So the bottom line is there any role of neoadjuvant chemotherapy in low-grade serous cancer, or you would take a chance in each and every patient and
We consider these as generally less chemosensitive, but that's not 100% of the cases. And right now, the recommendations remain that we treat them as ovarian cancer, whether it is in the neoadjuvant setting or the adjuvant setting. We do have to consider chemotherapy because the 20% to 30% patients will respond. We give her the benefit of doubt. If you're not able to achieve R0, that's worse, isn't it?
Okay. Dr. Jaya, do you agree that around 30% of the patient will respond to chemotherapy? And would you consider giving NACT if your surgical colleagues feel that they can operate upfront and they can achieve R0?
also I think for a
Sorry.
low-grade serous, upfront surgery would be the standard. However, if the surgeon feels that, there is no way they can go in and open the abdomen, that is the only situation where I would give neoadjuvant chemo, because only 20 to 30% of these patients would respond. So there's, as long as they're able to do a safe surgery, I think we would go ahead with upfront cytoreductive.
So this patient received 3 cycles of neoadjuvant chemotherapy. She had stable disease after 3 cycles. She was planned for interval debulking surgery, but at that time we were hit by COVID pandemic. Surgery was delayed. She was started on hormonal therapy, to which there was some response. And finally, she underwent surgery in July 2020. It was a R0 resection. What would be your next line of therapy? Would you give her chemotherapy or you'll continue with hormone therapy?
You already showed the answer, but I think because she had no response to chemo in the first place, and had a response to hormone, we would continue. And in fact, many of those patients that we had, if they've not had a response to chemo and then not operable, after hormone, some of those patients have had a response to it.
So this patient was continued on letrozole and she had a progression-free interval of 2 years. And then she finally progressed, then she had gross ascites again. So what would be your choice of therapy now? Dr. Lakshmi Haridas, what would you choose out of these?
I'll see if the patient is symptomatic or not.
She has
Definitely the
gross
patient should be
ascites, she is symptomatic. Yeah.
So I would prefer chemo in her case in this type. And I will also reserve ERPR status
for.
She's
giving
ERPR positive right from the beginning. I showed you the slide.
Okay. So at this time, I would consider next line of chemo.
Dr. Jaya, what would you consider?
So, of course, you've shown that option of MEK inhibitors, trametinib is approved drug in this situation, but we don't have, I mean, there is very limited access to the drug. So of course, if one had an access to that drug, that is a choice. Of course, I don't have any personal experience with use of MEK inhibitors, and I would use chemotherapy, platinum-based chemotherapy again in this patient because she's like 2 years platinum-free and had at least some chances of response to platinum.
This patient was started on paclitaxel and carboplatin again, but there was no response after 3 cycles. Now what would you do? And this is the last question. Dr. Lakshmi Haridas. She received 3 cycles of paclitaxel and carboplatin because there was a platinum-free interval of more than 2 years. There was no response. What would you do? Dr.
would
Rema
again
P,
add
would you
hormone-
consider her for surgery now?
The response we know is less and we already proved she's not as.
But she has gross ascites, extensive momental peritoneal disease. Would you?
Ascites, some mental deficit, nothing against surgery. She always has the option of surgery. She's a young patient, low grade disease, so definitely she has an option. I wouldn't consider neoadjuvant also. primary discovery.
So in the interest of time, we have to conclude the discussion here. Thank you so much for the wonderful discussion.
Thank you.
Any last question from the audience?
Yeah, I think we can have a couple of questions from the audience if anybody
We
has.
can have only 2.
Yeah.
Our inauguration
Last-
ceremony has to start at 3:30.
Huh?
Patient gets DVT on letrozole. I had a patient of LGSD who was put on post-treatment on letrozole, then she developed disease and with DVT. So what is the next option that we can offer them?
We are not-
When they develop with hormones, when they develop DVT?
So usually we don't see DVT so commonly with letrozole, but it may be because she had a disease progression at the same time that she had DVT. And as we said that, these, any of these options, and if she's like having, it's like, I don't think we have a standard line for management after, chemo and hormones. So it could be anything like if she, I mean, I would treat her how I would treat another platinum resistant ovarian with, maybe
she is
weekly
not
family because she has
So we can have this-
ascites or other hormone move on to exemestane, but these are areas where we really do not have much.
We have 2 more quick questions.
Yeah, no, we have some time. We can have 1 or 2 more questions. No worries.
For the first case, can we go to for brachytherapy post-op intravaginal brachytherapy?
There is
for
no
this
evidence
patient?
there is no evidence in support of using,
Right.
I know the evidence in neuroendocrine carcinomas is anyway very
So one
scarce.
last question.
But then there is no evidence, to use the brachytherapy alone.
Okay, thank you.
So last question from Dr. Gupta, and then we conclude this session.
My question is to Dr. Jaya Ghosh and the other medical oncologists also. So our pathologist has also stated that sometimes it is really difficult to figure out whether it is primary mucinous carcinoma of the ovary or it's secondary from the GI tract. And because there is no difference between paclitaxel and carboplatin and a GI-like chemotherapy, should we start giving GI-like chemotherapy to all mucinous carcinomas in the adjuvant setting? Which will also take care of the 10 to 20% or 15% misclassification as well.
I mean, of course, once that would be, before we start any patient on paclitaxel and carboplatin, we would at least go back and do their upper and lower GI endoscopies, and even if these are normal. I mean, what you're saying is that if there is an occult GI primary which is not picked up and GI tumor markers are also negative. So that is an answer that I don't know, I think, because, and whether we should change practice, I think, I would think that because what I realized is some of the centers do paclicarb and some of the centers do a GI-like regimen, maybe just,
We also do like exactly like the same, sir. Like if you have a mucinous histology, we go before embarking on any treatment like surgery, or if systemic therapy, we do GA scopies and CA 225 ratio and get an idea whether it's maximum idea whether it's could be an primary or meds from GI tract. So our practice is currently 6-pack carbo. Even though we have a retrospective data which goes in favor for the GI based regime,
We are done.
we have not changed practice. We have not generalized it to all patients. Still, we go ahead with 6-pack carbo.
Thank you.
Thank you.
Sudeep, may I ask you a question regarding the same? When we say mucinous tumors are less chemosensitive, is it because we are using the wrong chemo drugs? And if you use the GI drug, one of them, along with that, you may get more response?
Sir, I think Jay already has the mic, so maybe Jay, you can answer. No, no, go ahead, go ahead, go ahead. And it is my prerogative as an audience to request the panelists to please.
So please go ahead and then I'll say so. Sir, I do not know in the adjuvant setting, but what I've realized that when these mucinous tumors come back in the metastatic setting, they actually do not respond to either. We've used a GI-like regimen in the second line. So they have not budged with even the GI-like regimen, whether we've used Folpox or Folp3 or, liposomal doxorubicin. Of course, I don't know the answer in the upfront setting, but they are very chemo resistant when they relapse, irrespective of what type of chemo that we use. I don't know,
Thank
sir,
you.
does it-
Thank you, all of you. I think on behalf of our co-chair, I'd like to again thank the organizers for organizing this wonderful panel on this condition. And there were 9 panelists and they gave the expert input and 2 dynamic moderators
Yeah.
who
Thank
led
you.
the discussion.
Thank you.
And a very engaged audience. And just for 5% of this condition, we had a very intense discussion. Thank you all of you.
Thank you so much.
Very interesting discussion.